Hello, everybody. I know more people are still getting their lunches, so I asked that we've asked to get started. Really excited that you decided to come to Denver in the 3rd annual NCODA Spring Forum. We've grown quite a bit in the last couple of years, as some of the signs may have indicated. This meeting a year ago was in Dallas, and I think we had about 185 folks. We've got about 220, 230 NCODA participants, members here with us today. So it's quite a testament to the activity and the support that you all provide. Support that you all provide extends beyond just our membership, but also with our strategic partners like Asco. And I'm thrilled to have Erin Kennedy here with us and Amy Evers, a friend of mine from Asco, that we've been working together for probably about a year or so now on something that we wanted to share with you that's in the works. We've got it started here in the last couple of weeks, and we're committed to the Asco NCODA Oral Oncology Quality Standards Initiative that you're going to learn a little bit more about. Maybe click the next slide. I'm going to give a quick introduction just to tee it up a little bit for some of the folks that are new to NCODA. And just try to position this in this initiative so that it grounds us and kind of level sets why we've decided to partner with such a strong partner like Asco on such an important initiative like oral oncology quality standards. Our tagline at NCODA, as you've seen, is passion for patients. That's what we're all about. There's 2 guiding values that define NCODA. First is being patient-centered, and 2, being collaborative. And this is what I find and see with strong partnership with Asco. Extremely patient-centered and extremely collaborative. That's why we 3 are up on the stage today to share with you this important initiative. It all stems from myself being back at the practice in upstate New York about 5 years ago and trying to fill a prescription. We've all been here. If you're sitting out there in the seats, I'm sure you can all relate to the situation where you're trying to adjudicate a claim, you're trying to get an oral oncolytic out the door to support patients, and you can't fill the prescription. It was a tipping point for me on a Friday afternoon, as the story always goes, where you run into hiccups and problems with a patient that had glio, a woman in her 40s, needed Temodar, needed to go back on Temodar and radiation on Monday morning, of course, had new strengths, couldn't fill the prescription locally at our medically integrated pharmacy because the insurance company said that it would have been of an exception. We've probably all been there. So she starts crying, the husband starts crying, and I realized we needed to do something. We needed to do something. Instead of letting gravity take over and having all these external stakeholders dictate how we practice medicine, we needed to take charge to create positive change for patients. There's a need for better patient care. We all recognize that. We need to be proactive. And how do we become proactive? I sat back with our team as we started NCODA about 5.5 years ago, and we said the framework for that would be quality standards. What is the recipe? What's the framework that can be used to show and demonstrate what great looks like? And that is the NCODA quality standards. Health information technology, patient-centered, foundational, positive quality intervention. Those 4 separate domains represent what good looks like from a medically integrated pharmacy perspective. When you have those quality standards and you've adopted those and embedded those into your practice, it allows you to have opportunities to collaborate with payers, to have those discussions of quality and value where you can demonstrate your value to a very important stakeholder, the payer community. We've done that. We know that. People in this room have had those discussions. Where we're able to go beyond the first fill. In other words, keep that prescription at the practice for that continuity of care. Critical for patient care. Think about if I had that capability for that patient that had glio, that needed Temodar, and I had that capability to say, no problem, just wait a couple minutes, I'll have your prescriptions ready for you. But instead, what did I have to do? I had to stay on the phone for 45 minutes to convince them not to, the word was penalize the patient $3,500 in order to get that medication. So by me spending my time, effort, and energy, like all of you do every day, we were able to give those prescriptions. But I was handcuffed. It took a lot of extra energy and effort, even though I'm trying to do the right thing for the patients, just like you. So going beyond the first fill is an opportunity for NCODA to leverage our existing quality standards, to build upon them with a strong partner, a partner that's extremely patient-centered and a partner that's extremely collaborative. So with that, I'm going to turn it over to my friend Erin, who's going to talk a little bit about her responsibilities with Asco, knowing that working together, we really do become stronger. So with that, Erin.
Thanks, Mike. Is my mic on? Yep. Okay. First, I'm going to start talking a little bit about ASCO, the American Society of Clinical Oncology. It's a society which you might already be at least somewhat familiar with. It's a world-leading professional organization representing physicians caring for those with cancer. We're founded in 1964 with headquarters in Alexandria, Virginia, and we serve nearly 45,000 members. The mission is conquering cancer through research, education, and promotion of the highest quality patient care. And we improve cancer care through scientific meetings. You may be familiar with the ASCO annual meeting that takes place every year in June. Educational programs, and we have peer-reviewed journals as well. ASCO promotes and provides for lifelong learning for oncology professionals, cancer research, improved environment for oncology practice, access to quality cancer care, expertise of a global network of oncologists, and educated and informed cancer patients. As I mentioned earlier, we have a global network of nearly 45,000 oncology professionals, and we're the only organization representing all oncology subspecialties. Members benefit from worldwide cross-discipline network of professional and personal expertise. We have actually 30% of members who are international and represent more than 120 countries. This is just the ASCO network. So we have asco.org, we have our journals, Clinical Oncology, Oncology Practice, as well as a number of other network components, so the ASCO Connection, ASCO University, CancerLink, cancer portals, Conquer Cancer Foundation, Cancer.net, the Quality Oncology Practice Initiative, and the QCP COPE certification program. So where I come in is with ASCO guidelines and standards, and this is the area where I work. So I've been working for about 10 years on mostly ASCO guidelines, as well as guidelines with the Cancer Care Ontario Agency in my home province of Ontario, and I've also worked on a number of standards. So this is more focused on guidelines, but it applies to standards as well. So our guidelines address a wide range of cancer treatment, diagnosis, and management issues. We publish guideline endorsements from other professional societies. We do adaptations. As I said, of course, we do standards, and we do provisional opinions when we don't feel like there's quite enough evidence to do a guideline or a standard. So annually, our whole team, we have about 8 members. We do about 25 new guidelines, and we update 15 existing guidelines per year. So we're very busy on guidelines. And then we engage a lot of volunteers with our program. So we have over 1,500 guideline or standards volunteers. And we've collaborated with 27 organizations on guideline development. So we're very keen on collaboration, including this current collaboration with NCODA. Our guidelines are consistently among the most accessed Journal of Clinical Oncology articles. So we're really happy that they reach a wide audience. Oh, this is just a screenshot of a standard. So it's an example of a standard we did on chemotherapy administration. We've also recently completed and published one on chemotherapy safety. So our development process, just a little bit about that. We invite 2 co-chairs usually to lead the panel. And our panel ranges from maybe 10 to 15 other experts. We develop a protocol, and this is kind of the core activity, is to conduct a systematic review of the evidence. So we want our guidelines and standards to be based on the best and most recent evidence that is available. So we do a critical assessment and we do an evaluation of all the research studies that are relevant to our clinical question or process or whatever we're looking at. And we have a very organized and standardized method of locating, assembling, and evaluating the body of literature. And external organizations have evaluated the quality of our guidelines and rated them very highly. And we're always trying to improve on our quality and our processes. Sometimes, though, there's not enough evidence, and there's just not any published evidence on a question. So we do also employ a consensus-based methodology amongst the expert panel when we need to do that. Okay, so for this standards project, right now, the systematic review that I just described, it's in progress. So in February, March, so that's pretty much right now, we want to be finalizing the systematic review. And March to April, we want to finalize the standard statements that are going to be based on that evidence. And our goal is to complete this project in the second quarter of this year. And our key publication will be in the Journal of Clinical Oncology. And it will be disseminated through our app and some other ways that we have of doing that. So we have clinical tools and resources that we produce to make our guideline implementable, podcasts, pocket cards, courses, and email, and all sorts of things. Okay, so the Asco NCODA oral chemotherapy dispensing standards. Early discussions of shared values and standards have occurred. The concept is to address the gap in oral chemotherapy dispensing. Yes, so we have future potential. Were you going to speak about this?
Yeah.
Okay, I'm sorry. So I'm going to pass it. Okay, so we have a potential to work with NCODA to help us speak with payers and employer groups to go beyond the first fill. But Amy's going to speak to that more, and I'm going to pass it over to her now.
So once these standards are published, the plan is for the COPE certification program, which many of you are already COPE certified, will be adopting some of these new standards into our practice with the hope that we can add a separate part of certification onto our current certification process just for practices that have in-office dispensing. So I think this process is going to be invaluable to ensure that, as Mike mentioned earlier, that we, the experts in oral dispensing, are the ones that are setting the bar on the quality care that we're going to be giving these patients for continued in-office dispensing. So right now it's just very preliminary in how that's going to look. We've envisioned and already taken a look at the current existing NCODA standards and how they go beyond the current COPE certification standards. And many of them are already embedded. Our standards are pretty, I don't want to say vanilla, but as far as oral adherence, initial adherence assessments, and then ongoing adherence assessments are really defined by your practice. But hopefully with the development of these standards, we'll have a little bit more straighter guidelines about what those expectations will be going forward. And then we hope that for those of you that are currently certified or considering adding COPE certification to your list of accreditations, that we can use this to go back to the payers and say, here, we've defined what quality oncology oral dispensing is, and then these are the practices that are meeting that, those standards. And so we're really looking forward to getting this project wrapped and then moving on to the COPE certification update process. We have other slides. Really, we have slides on the current COPE certification standards themselves, but they're really more if the current standards are really mostly focused on the IV chemotherapy, but as we've all seen in the 3 years that I've been with Asco and managing this program, we've seen a tremendous growth in the oral oncology space, and we've really gone beyond just needing to focus on quality standards just for our IV patients and focusing more on what we're doing for our oral patients as well. I think one of the struggles that I've seen many of our practices have to deal with is that they have really great processes in place for their IV patients. Consent process is very clear. It's part of, they have an education process that's developed as part of the IV chemotherapy consent. But then when it comes to oral patients, they're kind of handled differently because they think about them as a different population of patients. And I think that that's really no longer the case. So making it clear that there is an important differentiation between practices that have in-office dispensing and practices that don't, and being able to demonstrate that quality not only to ourselves and to other practices, but to the payers as well.
Erin, I know that you can't necessarily share the, the names of the individuals on the committee, but maybe you could share a little bit about how the process is, and the kind of the quantifiers of the makeup of the committee. That might help people understand who's involved in this expert committee.
Mm-hmm. Yeah, so what we usually try to do is have definitely representation from every specialty that would be relevant. So in this case, we have a physician representation, we have pharmacy, we have nursing, administrative representation, and as well, for every one of our guidelines, we need to have a patient representative. So we have a patient we've invited to join the expert panel, and then we try to also have it geographically represented across the US and even internationally if that's relevant, and just have diversity across, just all sorts of whatever would be the relevant things that we would want to account for. Mm-hmm. Yeah.
Very good. Mm-hmm. And I'd like to just have folks try to understand the importance of this initiative and where this could go. The point that I was trying to make earlier in my presentation is being proactive, right? Taking an opportunity to change the status quo is why I started NCODA. This is an opportunity to take that concept and put it on steroids, so to speak, in a sense of taking, going beyond the first fill concept that we've had successes at 8 practices with 12 payers and employer groups across the country, and augmenting that in a way that's more formal, augmenting it in a way that's more recognized and strengthened by having a strong collaborative partner like Asco. So if you can envision this being an opportunity to go to a payer knowing that you have a stronger likelihood of collaborating with those payers to show quality and value, to get that capability to go beyond the first fill is huge. Practices that have that capability, the ones that I know about, it's a game changer for the patients. It also helps out the practice. It also helps out your healthcare team. It creates that win-win-win situation that everybody is trying to find. So with that, I congratulate my Asco colleagues for agreeing to meet with Jim and myself probably about April of last year, and finally coming to a point now where we've got the committee started. We're having those initial dialogues. We're starting to do the research to build the formal process in order to have this completed with a target completion towards the second quarter of this year. So it's very exciting, and I welcome you guys to ask us some questions after the presentation, after lunch, or later tonight, on what this could mean to you and how you could get involved. So with that, thank you.